Evening, everyone. This is the first of 2 or 3 perhaps lectures which is meant to introduce you to clinical assessment of the child with congenital heart disease. No doubt, when you see a child, encounter the child for the first time in your outpatient clinic or emergency room or in the cath lab, there is a way that you evaluate the patient based on the history, the clinical features, and then only you go on to look at the investigations, do an echo, you're going to catheterize the child. Whatever form of investigation you are going to take will depend on what initial assessment based on the history and the clinical that you have done. This lecture is to enable you to understand the symptoms of a child with the physiology behind it, to help you to draw a conclusion that will lead to the group of diseases which could cause the symptom, or in some instances the actual disease which is causing the symptom. Let's start with dyspnea. All of you are aware of what dyspnea means. It is an unpleasant awareness of one's own breathing. You use the word tachypnea often, where there is no actual reference to the subjective sensation. It's a counting of the respiratory rate. And the normal respiratory rate in an older child or infant is more than, an abnormal respiratory rate is more than 40 per minute. And in a neonate, it should be more than 60 per minute to merit the term tachypnea. What does dyspnea mean to the cardiologist? It means that either the pulmonary venous pressure is elevated or that the child is hypoxic. Some terms which are specific for dyspnea are orthopnea and paroxysmal nocturnal dyspnea. Orthopnea, as you would have learned in your undergraduate days, is dyspnea occurring within minutes of lying down. This is because the venous return increases as the patient is lying down and the movement of the diaphragm decreases. And the word paroxysmal nocturnal dyspnea should be reserved for the specific symptom of left heart failure, which occurs 2 to 3 hours after sleeping. The patient gets up and it's relieved in the sitting position in a few minutes or maybe slightly longer. Why does this happen? During the REM phase of the sleep, the increased sympathetic activity would cause peripheral vasoconstriction and tachycardia, which adversely affects a failing heart. And in the NREM sleep, the withdrawal of the sympathetic support could also be deleterious to the patient. Let's look at how exactly dyspnea results. For dyspnea to happen, the pressures in the pulmonary veins have to go up. This ordinarily means an elevation of the left atrial pressure. You can have normal left atrium and elevated pulmonary venous pressure in obstructed TAPVC. So the pulmonary venous pressure has to go up. Maybe in the pulmonary veins itself is the cause due to an obstruction, or within the left atrium, or within the inflow into the left ventricle, or all this is okay, but the left ventricular end diastolic pressure is elevated, as a result of which the LA mean pressure is elevated, which is reflected onto the pulmonary venous pressure. So the left ventricular failure causes a rise in the LV ADP, or an LV inflow obstruction causes a rise in the LA mean pressure. This is reflected as pulmonary venous hypertension. The result is transudation of fluid in the interstitium. Once there is fluid in the interstitium, there is an increased respiratory effort that is needed to move the congested lungs. And you know the J receptors in the pulmonary interstitium. Stimulating the J receptors, it drives the respiratory center to work faster. And increased inspiratory effort without proportionate lung expansion leads to retractions in the intercostal and subcostal regions. Something that goes with dyspnea is intercostal and subcostal retractions in infants, and this happens because There is a greater inspiratory effort to deal with the increased fluid overload in the interstitium, but this inspiratory effort does not result in a proportionate lung expansion. As a result, there is a retraction in the intercostal and subcostal regions. This is all in relation to left heart disease. If you are dealing with hypoxia as in cyanotic congenital heart disease, it's a very different story altogether. The hypoxia leads to acidosis because tissue metabolism is now anaerobic. Both these, a drop in PO2, arterial PO2, and a drop in pH, they stimulate the respiratory center, and the respiratory center stimulation results in tachypnea. You're familiar with grading of dyspnea. The NYHA grading grades class 1 as no dyspnea but diagnosed heart disease. Class 2 is dyspnea on ordinary activity. Class 3 is on dyspnea on less than ordinary activity. And class 4 is an inability to perform any activity without dyspnea. You can imagine that in small babies, this classification cannot be applied. That is why the Canadian Pediatric Society has come with a ROSE classification of dyspnea for infants. Class 1 is again asymptomatic. Class 2 is mild tachypnea or sweating with feeding in infants. The equivalent of that is class 2 dyspnea in older children. Class 3 is marked tachypnea or sweating with feeding, or marked dyspnea on exertion. If a baby has a prolonged feeding time as a result of this, it results in growth failure. So a child with obvious failure to thrive as a result of heart failure would belong to at least class 3, if not 4. Class 4 is manifest retraction, grunting, or sweating at rest. In hypoxia, it's a different story, as I said. Exercise results in an increase in the heart rate as well as venous return. There is a systemic vasodilatation in exercise. The tachycardia, the increased venous return, all these lead to an increase in the right to left shunt. Consequently, there is a desaturation. So the drop in the arterial PO2 would stimulate the respiratory center. Concurrently, the hypoxia would lead to acidosis, and that also would stimulate the respiratory center. All these results in dyspnea. We move to another symptom, feeding difficulty. It is the main symptom of heart failure in infants. You need to elicit from the mother what would be described as a suck, rest, suck cycle. This results from dyspnea and fatigue when the baby sucks. When the baby sucks at the nipple, the baby becomes breathless, and it would stop after a small feed. During this break, you can observe the baby to be dyspneic, tired, and sweating in the forehead. As this baby rests for a few minutes, it gets the ability to suck again. So this is why you say that there is a suck, rest, suck cycle. Suck, dyspnea, rest, recover, suck, dyspnea, rest. That is the cycle. When you have heart failure in the infant or older child, the general features would be respiratory distress, sweating, cardiomegaly, hepatomegaly, and often a low blood pressure. It's important that not only you do recognize congestive heart failure from the symptoms, but you note the actual timing of presentation. If you're seeing a 3 months or a 6 months old baby, in the last 3 or 6 months, when exactly did the mom observe the symptoms of heart failure? Is it on the day 1? Is it in first week? Is it at 3rd month? It makes a lot of difference to help you to draw conclusions. We would illustrate this point. To the baby who is actually in heart failure on day 1, before I discuss this, I should warn you of a very common mistake. As far as the mother is concerned, In casual history taking, day 1 is a nebulous day. She probably only means in the first several days of life. It is up to you to make sure that on the day of birth, these things existed. Don't take it for granted from the mother's or the grandmother's words. Elicit that history yourself and cross-check, because as you can see, the first in the list is hydrox fetalis. If there is heart failure on day 1 at birth, quite often it's hydrox fetalis, and quite often it's not cardiac. It is a cause like intrauterine hemolysis. It could also be cardiac, like an intrauterine myocarditis or an ongoing supraventricular tachycardia, and the baby has just been born, but the baby was in hydrox. On the other hand, a few hours later, on day 1, if the baby develops dyspnea or shock, that is a feature of obstructed TAPVC. On day 1, it's very likely infradiaphragmatic, but supracardiac TAPVC can also present with obstruction on day 1. Hypoplastic left heart syndrome tends to present with heart failure and or shock towards the later part of day 1. Severe tricuspid regurgitation as an Epstein's anomaly or severe pulmonary regurgitation that goes with an absent pulmonary valve syndrome can present with heart failure on day 1. In the case of absent pulmonary valve syndrome, the symptoms of respiratory distress due to airway compromise, they tend to get overlapped and they tend to dominate the presentation. An extracardiac AV malformation like an aneurysm of vein of Galen could present with heart failure on day 1. If it is later than day 1, later in the first week, all the causes that we discussed on day 1 can also present later in the first week, except that hydrox fetalis, if it is present, has to be present at birth. All the other causes can present a little later in the first week because they are generally related to a ductal closure. The duct, instead of closing in the first 24 hours, if it closes in 48 or 72 hours, it could present a little later. But by and large, heart failure in the first week of life denotes left heart obstruction. Remember this. Heart failure in the first week of life, the commonest cause is left heart obstruction. Critical aortic stenosis, hypoplastic left heart syndrome, coarctation or interrupted aortic arch, all these tend to present with heart failure and or shock in the first few days of life. Obstructed TAPVC, instead of presenting on day 1, could present later in first week also. After the first 2 weeks are gone, meaning if the baby was all right in the first 2 weeks, and on 3rd week or on 4th week, the symptoms have started. This is the time when shunts start manifesting. Typically, a large VSD or a large PDA would tend to present around 6 to 8 weeks when the pulmonary vascular resistance has dropped to near adult levels. But sometimes, especially in preterm babies, their presentation may be earlier. Preterm babies tend to tolerate shunts poorly and manifest with heart failure much earlier. Also, children with complex congenital heart disease and cardiac failure, like cyanotic congenital heart disease with increased pulmonary blood flow, TGA with VSD, truncus, they tend to present towards the later part of the first month. Towards the end of first month, anomalous origin of left coronary artery from the pulmonary artery also creeps into the list. It classically occurs at 2 months or 3 months of age, but from the later part of first month, this entity should occupy a name in the list of differential diagnosis. Why not earlier? In Alcapa, what causes heart failure is the runoff from the aorta to the pulmonary artery, not the fact that the coronary artery is arising from the pulmonary artery. The coronary artery becomes a conduit for runoff from the aorta to the left coronary, collaterals to the right coronary, to the pulmonary artery, and therefore myocardium suffers from ischemia. In the neonatal period, the high pulmonary vascular resistance prevents much runoff. That is why it is unusual to find an Alcapa presenting in the first 1 or 2 weeks of life. Now let's think of the older child. We spoke of the first day, the first week, the first few weeks, or the period from 1 month to 3 months. If you had a child who was okay during all this period, but later in the first year of life, or even later, if the child is presenting with heart failure, you could still be dealing with a large shunt or a complex congenital heart disease with a significant shunt. But during this time, Alcapa, a late presentation of coarctation and aortic stenosis, viral myocarditis, and arrhythmias, they figure in the list. Arrhythmias, of course, in all the age categories, a sustained SVT or a permanent form of junctional reciprocating tachycardia. These type of sustained arrhythmias could present with heart failure at any age. But if a baby has been all right in the first few months and then it presents with heart failure, Alcapa, coarctation, aortic stenosis, viral myocarditis, arrhythmias, all these should be thought of. We spoke so far about heart failure. Shock often goes with heart failure. Sometimes it might present independently also. When shock is the presenting symptom, the left heart is at fault as a rule. Coarctation, critical aortic stenosis, hypoplastic left heart, or viral myocarditis or arrhythmia could present with shock in the neonate. Moving away from heart failure, an important symptom in the older infant is the failure to thrive. You apply the term to children below the age of 5 years. You say that a baby is failing to thrive. As pediatricians, you know when the baby's weight is below 3rd centile, or if you're looking at the weight for height C-score, if it is less than 2 standard deviations for the appropriate age. That is when you say that there is failure to thrive. Why do children with heart disease get failure to thrive? In congestive heart failure, there is feeding difficulty and decreased caloric intake. There is an increase in the catabolism. In heart failure, recurrent respiratory infection increase the need for more calories at a time when the baby is unable to consume it. And systemic venous congestion in right heart failure causes portal venous congestion, anorexia, and decreased absorption from the gastrointestinal tract. The upper GI congestion reduces the appetite and reduces the ability to absorb the ingested food. Or failure to thrive may be a part of a syndrome like DGeorge or rubella or Downs, where inherently the syndrome is going to be associated with failure to thrive. So even if the heart lesion is minor, the baby may fail to thrive. Recurrent infection may be a feature of a left to right shunt, or it may also be because of a low immunity, as in DGeorge syndrome. And recurrent respiratory infection, now let's address it as a separate feature of heart disease. What do we mean by recurrent respiratory infection? It's very common in history presentation to hear that this child has cough cold. Don't do that. When you speak of cough cold, it means nothing as far as conclusions with regard to cardiac diagnosis concerned. You're referring to 4 to 6 episodes of lower respiratory infection in a year, or at least 2 episodes requiring hospitalization or IV antibiotics. Why do you want to lay down criteria like this? Respiratory infections are particularly upper respiratory infections are very common in children. So if you want to draw the conclusion that this is significant to be correlated with a potential heart disease, the severity of the respiratory infection should have some yardstick to measure. It should be one which should have received IV antibiotics at least twice. Or it should be episodes which should have required hospitalization at least twice in a year. And then you can consider it significant. Or if hospitalization was not required, let us raise the bar and say that there should be 4 to 6 episodes of lower respiratory infection. This is a feature of post-tricuspid shunts. like VSD, PDA, AP window, or complex congenital heart disease with increased pulmonary blood flow. In these instances, there is a left ventricular failure and pulmonary venous congestion. As a result, we already explained how left ventricular failure results in pulmonary venous congestion. The interstitial edema and the pulmonary venodilatation would cause compression of the bronchioles, and this would tend to have retention of secretions. Remember, the same loose areolar tissue houses the pulmonary venules and the bronchioles. So if the pulmonary veins are distended, it is at the expense of the space for the bronchioles. And remember, bronchioles at this level have no cartilage, so they are readily compressed. So an interstitial edema can readily compress the terminal bronchioles. This will cause wheezing. It will also cause retention of secretions. And when there is a chronic pulmonary venous congestion, anastomotic channels would open up between the pulmonary veins and the bronchial veins, leading to bronchial mucus congestion. And this congested bronchial mucosa invites infection. The congested bronchial mucosa is associated with a goblet cell hypertrophy. So this is associated with a reduced mucociliary clearance. In addition, a dilatation of the left pulmonary artery, as would often happen in the case of a large VSD or a PDA, the dilated left pulmonary artery would compress the left main bronchus, resulting in retention of secretions and impaired clearance of secretions, and thereby inviting infection. Also, poor immunity associated with poor weight gain is a predisposing factor for recurrent infection. So there are multiple reasons why recurrent respiratory infections could occur in a child with heart disease. Generally, it denotes a heart disease with a large left to right shunt post-tricuspid. But there are other factors which are operating. But before you blame the heart for recurrent respiratory infection, be sure that your recurrent respiratory infections are recurrent enough and serious enough to warrant such a correlation. Now we move to another symptom, exertional fatigue, which denotes an inadequate skeletal muscle perfusion during exercise. It's a feature of reduced cardiac output. And the causes would be a fixed obstruction to the right ventricular outflow. This may be either there is severe valvar stenosis or pulmonary hypertension, or a fixed LVOT obstruction, which may be valvar, subvalvar, supravalvar. This fixed obstruction restricts the extent to which cardiac output can rise with exercise. It may not rise at all. And therefore, as the person is exercising with a fixed cardiac output, the skeletal muscles do not receive adequate perfusion, and they cry out, and that is the fatigue in the exercising muscles. Syncope is a further step away from this. Syncope is a transient loss of consciousness due to decreased cerebral perfusion. This may be exertional, or it may occur at rest. When there is exertional syncope, it means the heart is unable to increase its output in the face of exercise-induced peripheral vasodilatation. During exercise, there is a dilatation of arterioles in the exercising muscles. Any arteriolar dilatation tends to pull down the systolic blood pressure unless the heart is able to increase its output to fill this dilated vasculature. When the LV output is fixed, or when the RV output or both the outputs is fixed, the patient is exercising and the output is not increasing, but the vessels are dilating in the exercising muscles. The result is a drop in blood pressure. Cerebral perfusion suffers and syncope occurs. When the patient hits the ground, as the person is in the recumbent position, cerebral perfusion is restored and the consciousness is all right. In conditions like aortic stenosis, there is also a receptor-mediated mechanism. The mechanoreceptors in the left ventricular myocardium can trigger a Basol-Jarisch reflex, a vagal receptors being stimulated and as a result getting bradycardia, vasodilatation due to a cholinergic mechanism, and hypotension. So a Basol-Jarisch reflex could be triggered with exercise in severe aortic stenosis, and that could also be the reason for syncope. Exercise-induced arrhythmia could also be a factor for syncope in left heart obstruction or in right heart obstruction or pulmonary hypertension. So syncope is either due to an exercise-induced peripheral vasodilatation not compensated by an increase in the cardiac output, or an exercise-induced arrhythmia, or a mechanoreceptor-mediated reflex. And the group causes for exertional syncope on the right heart, think of primary pulmonary hypertension and Eisenmenger syndrome. Primary pulmonary hypertension in the relatively younger child and the Eisenmenger syndrome in the adult. Severe LVOT obstruction at any age. Syncope at rest is a different ballgame. It can be a vasovagal syncope, which classically occurs in situations of prolonged standing. All of you would have experienced a vasovagal syncope sometimes, standing in a school assembly, standing in a queue for a long time, especially in the hot sun. There is a peripheral vasodilatation, and temporarily the heart is unable to increase that output, and hence the patient falls down, the subject falls down, and when he hits the ground, cerebral perfusion is restored. So syncope at rest, a vasovagal syncope is a very common thing. On the other hand, if it's related to a condition such as left atrial myxoma, some posture can obstruct the left ventricular inflow, and that can lead to syncope. You also have a very characteristic sequence of events in Stokes-Adams attacks, which is syncope in complete heart block or other causes of profound bradycardia. What happens is the profound bradycardia comes abruptly, and as the bradycardia comes in, the person starts becoming pale, and he could die in an arrest. But more often, if he recovers, then he starts flushing and becomes all right. That is the sequence in a Stokes-Adams attack. It is intermittent complete heart block or any cause for profound bradycardia. You could get syncope under specific situations which are diagnostic of certain conditions. We said positional syncope characterizes LA myxoma. Similarly, if you have syncope while swimming, syncope after running, or you heard a loud sound, the patient heard a loud sound and went into a syncope. These are suggestions of long QT syndrome. And the specific trigger factor for syncope would even help you identify the subtype of long QT syndrome. Palpitation is a different symptom. It's an unpleasant awareness of one's own heartbeat. Whenever somebody complains of palpitation, you need to make out whether it's an exertional palpitation, it's a palpitation at rest, or is it a paroxysmal palpitation. Exertional palpitation is a feature of the volume overloaded heart. The atrial septal defect, mitral regurgitation, aortic regurgitation, all these in the older child or adult could present with palpitation on exercise. As the heart is enlarged and volume loaded, with exertion, it beats faster, its force of contraction is more, and the patient recognizes this. Palpitation at rest may also occur due to volume overload, especially when the patient is lying down and turning to the left side. The dilated left ventricle is brought into contact with the chest wall, and the patient becomes subjectively more aware of his own cardiac activity. That's palpitation at rest. Importantly, you should be able to recognize what is a paroxysmal palpitation, which is pathognomonic of arrhythmia. Paroxysmal palpitation is abrupt in onset. It is always abnormal. The offset, the termination, is generally abrupt But sometimes the termination of the tachycardia may overlap with a sinus tachycardia, and you may not recognize an abrupt termination. So an abrupt onset is little more important than an abrupt termination. So in this, the maximal heart rate is achieved in a beat's time. The patient is able to say that I was reading a newspaper. I was all right when I was reading a newspaper. Suddenly my heart started beating. And if you can ask the patient to tap out how his heart beats, it will be like this, as against a normal, steady cadence of heartbeat. Parents may note that there are neck pulsations or cardiac pulsations. Rarely they may notice that there is polyuria during the palpitation. And they may notice that a vagotonic maneuver like straining a stool or gulping down water may terminate the palpitation. What helps you to recognize that it is paroxysmal? It is unprovoked. It happens abruptly. The maximal heart rate is achieved in a single beat's time, and generally it disappears quickly. It may be accompanied by polyuria, may give you a history of termination with straining a stool or drinking water. Chest pain in children, it's very important to realize, is very, very rarely only is cardiac. It's very common these days to find parents bringing children with a history of chest pain. I would start with the presumption that this is going to be non-cardiac. Children run around, play, and musculoskeletal pain from somewhere in the chest wall is the commonest cause for chest pain in a child. Very uncommonly, repeat, very uncommonly, there could be a cardiac reason for chest pain in a child. Pericarditis is one such reason. If the child has fever and is complaining of chest pain, it's probably pericarditis. Also, in a post-op child, pericarditis is a common cause for chest pain in the post-op phase. Most serious causes are exceedingly rare. Coronary abnormalities like Alcapa, if it has survived into an older child or an adult, might present with chest pain. Abnormal course of the coronary arteries. A coronary artery may course between the aorta and the pulmonary artery, and during exercise, this may cause compression, and the patient may get an exercise-induced symptom. Or acquired coronary artery abnormalities can occur in conditions like Kawasaki's disease and Takayasu's disease, where you can get an angina-like situation. Distress and irritability during straining may be the angina equivalent in Alcapa in an infant. The older child or adult can get chest pain from a hypertrophied RV or LV in Eisenmenger syndrome or in LVOT obstruction. Mitral valve prolapse has been described as associated with chest pain, and various theories have been advanced for this, that the prolapsing chordae are pulling on to the left ventricular muscle. But most often, when a patient with mitral valve prolapse complains of chest pain, it's a musculoskeletal pain which has nothing to do with the mitral valve prolapse, and what the patient needs is a firm reassurance that MVP is by and large a benign disorder. Moving to something different, edema, or its infantile equivalent facial puffiness, it denotes systemic venous hypertension. The cause is congestive heart failure. If there is severe tricuspid regurgitation, as in a post-op tetralogy, or severe Epstein in a small baby, a post-op right ventricular dysfunction as in a tetralogy, or severe pulmonary hypertension, as in primary pulmonary hypertension, could be a reason for tricuspid regurgitation, high RA pressure, and facial puffiness. Cyanosis is a very different symptom. It is both a symptom and a sign. So we will discuss cyanosis in some detail. You define cyanosis, as all of you know, as a bluish discoloration of skin and mucous membranes due to an increased concentration of reduced hemoglobin in the circulating blood, in the capillary blood. If you are looking at the reduced hemoglobin concentration in the capillary blood, it needs to be more than 5 grams per cent to manifest cyanosis. But in the ABG, a drop of 3 grams per cent is enough to cause cyanosis. And the cyanosis, if you're seeing in a newborn, do not necessarily presume that it is cardiac. Remember, there could be a neurologic cause, abnormal ventilation, musculoskeletal system, which is interfering with the child's breathing, an airway obstruction, which is interfering with alveolar oxygenation, an abnormality of the alveolar capillary membrane, as in an ARDS, all these, and an abnormal hemoglobin, all these could be causes for cyanosis. The heart can also be a cause for cyanosis. In the neonate, be very careful that you have excluded non-cardiac causes. Once you have concluded that there is a cyanosis, you try to make out whether it is central or peripheral. If the extremities are cold and cyanosed, it is a peripheral cyanosis. And warming the patient, like putting the patient under a warmer or using a blow warmer, that would cause this type of cyanosis to disappear. And once you are able to get an SpO2 measurement, that will be normal. The other question when you see a cyanosis, and that to a central cyanosis, is whether it is cardiac or respiratory. You face this question quite often. The key clue to make that conclusion is a peaceful cyanosis is cardiac. The baby looks otherwise fine, but he is just cyanosed, and that is cardiac. On the other hand, cyanosis with respiratory distress means that there is a pulmonary problem, like in a pneumonia. It is cyanosis with a respiratory distress. But an overlap comes in conditions like obstructed TAPVC, because the baby is in pulmonary edema. Baby will be in distress, and the baby's saturation will be lower. Barring that, you could say that a peaceful cyanosis is cardiac, typically illustrated in the baby with TGA or Tetralogy pulmonary atresia in the newborn period. And the baby in respiratory distress with cyanosis is respiratory, and classic illustration will be a baby with lobar pneumonia. When you see a cyanotic baby, you should have a certain way to look at that baby, to evaluate that baby. The first question, is the baby actually cyanosed? Check the SpO2. Not only look at the tongue or the lips, but in the current era, check the SpO2. And when you check the SpO2, check it in both upper limbs and lower limbs, because there could be a differential cyanosis. And if you find that you have a good pulse trace and the value is less than 94%, it is abnormal. Then the question is the cyanosis central or peripheral? By keeping the baby warm, you will get the answer. You kept the baby warm, your SpO2 is still low, that is central cyanosis. You kept the baby warm, the SpO2 is normal, you get a good pickup now, which is not there earlier, that's a peripheral cyanosis. Then, is the cyanosis cardiac? We said peaceful cyanosis versus respiratory distress. You could also see the response to oxygen. In newborns, the hyperoxia test is very useful, which is done by giving 100% oxygen for 10 minutes with a mask. And you can check the ABG-PO2. If it is more than 300 millimeters of mercury, the cyanosis which was present earlier is respiratory. It can't be cardiac. If the PO2 is less than 150, it is very likely cardiac. In between, there is an overlap zone where conditions like TAPVC can present with a PO2 values between 150 and 300 on 100% oxygen. The typical ABG profile of a cyanotic congenital heart disease in the absence of any overlapping lung problem is a low pH, a low PO2, and a low PCO2. Why is the pH and PO2 low? Because the arterial oxygen saturation and the arterial oxygen tension are low. Why is the PCO2 low? The lungs are normal, and therefore with the hypoxia-induced tachypnea, the lungs are hyperventilating and washing out carbon dioxide. If you look at the X-ray, the size of the heart, the configuration of the heart, and the vascularity, these are things that will help you to say what is the diagnosis. You know the most talked about egg on string appearance of TGA. We know the boot-shaped heart of a Tetralogy fallow. These shapes may not be always evident, but if you find that the baby is intensely cyanotic and the lung vascularity is normal, it is TGA. If the baby is intensely cyanotic and the lung vascularity is normal, it's TGA. The baby is intensely cyanotic and the lung vascularity is very oligemic, it's Tetralogy-like physiology. This is a rule of the thumb that you can carry. Just like the X-ray, the ECG axis and the RV or LV dominance, these are things that help you to reach a diagnosis. For instance, cyanosis and a left axis deviation in a newborn, you would think of tricuspid atresia. Just a word about classifying cyanotic congenital heart disease, because it is relevant in this context. We classify cyanotic congenital heart disease as having a reduced pulmonary blood flow or increased pulmonary blood flow. Reduced pulmonary blood flow, Tetralogy fallow, and Tetralogy with pulmonary atresia is the prototype lesion. But you can also have a number of other conditions where there is a large VSD and there is obstruction to pulmonary blood flow. We call them Tetralogy-like physiology. They are complex congenital heart diseases with like TGA VSD-PS, corrected transposition VSD-PS, truncus with PS, TORV PS, Taussig Bing PS. These are conditions which essentially have a large VSD and an obstruction to pulmonary blood flow. So they would merit the term Tetralogy-like physiology. In a very different way, a critical pulmonary stenosis or pulmonary atresia with intact ventricular septum would cause cyanosis. Critical pulmonary stenosis means severe valva PS, the RV pressures are systemic or suprasystemic, and there is a right to left atrial shunt causing desaturation. That is critical PS. If it goes one step further, the pulmonary valve is atretic, so it's a pulmonary atresia with intact ventricular septum. Survival depends on a right to left atrial shunt, and that would cause cyanosis. Epstein's anomaly can cause cyanosis in the newborn because there is a functional pulmonary atresia. The very hypogenetic right ventricle is unable to pump into the pulmonary artery against the neonatal pulmonary vascular resistance. So in the first few days in Epstein's anomaly, it's not uncommon to find cyanosis, and in some children, it can be very severe to warrant prostaglandin. But over a few days, at times requiring ventilation with prostaglandin, this settles. The common features we already said of cyanotic congenital heart disease with reduced pulmonary blood flow is a low arterial PO2, chest X-ray showing oligemic lungs, and response to prostaglandin in the neonate. Sorry. When you speak of increased pulmonary blood flow in cyanotic congenital heart disease, TGA is the prototype, particularly with a ventricular septal defect. TAPVC, single ventricle, truncus, DORV with subpulmonic VSD, these are some of the other examples. Or Tetralogy, pulmonary atresia, and multiple aortopulmonary collaterals causing cardiac failure. And the common features here would be cyanosis, of course, but cyanosis of a lesser degree than what you would expect in cyanotic congenital heart disease with reduced pulmonary blood flow. Cardiomegaly, the murmurs are generally unimpressive. You are familiar with the word cyanotic spell, but it's very important to define a cyanotic spell and not to use that term misleadingly. A cyanotic spell is a very life-threatening event. You use the word cyanotic spell when there is a rapid decrease in systemic oxygen saturation accompanied by hyperventilation. Rapid decrease in systemic oxygen saturation with hyperventilation. If you don't intervene medically, this could lead to convulsions, coma, or death of the baby. So it's a very major symptom. This should not be confused with cyanosis on crying. All babies who have cyanosis the cyanosis will worsen on crying. That is just exercise, the crying-induced cyanosis. The term cyanotic spell should be reserved for a life-threatening episode where there is a dramatic drop in systemic oxygen saturation and is accompanied by hyperventilation. The classical age group is usually 6 months to 2 years. It may extend up to 6 years, but more often it's 6 months to 2 years. Crying or exercise might trigger a spell. Why the spell occurs, whatever is the trigger, be it crying or be it exercise, there's a drop in systemic vascular resistance, or there may be an infundibular spasm which is mediated by the sympathetic overactivity. This results in a right to left shunt, and the tachycardia that goes with it, it causes a reduction in the ventricular volume and further exaggerates the right to left shunt. And because of the right to left shunt, the arterial pH is dropping, and this acidosis further triggers the hyperventilation. The hypoxia and the drop in pH both would stimulate the respiratory center into hyperventilation. Normally, when a baby is hyperventilating, there is an increase in the pulmonary blood flow, so it results in an increased oxygen delivery. But in the case of the baby in cyanotic spell, the increased activity of the respiratory center and the increased respiratory muscle activity, it is only a muscular activity. It's not accompanied by an increase in the flow. So in effect, it is only adding to the muscles which are acting anaerobically. So it further causes drop in the pH and further worsens the spell. This is the common mechanism of cyanotic spell. Should also know that there are criticisms of these mechanisms. For instance, Dr. Kothari from All India Institute has published a paper and argues that these theories can't explain cyanotic spell in many instances, and he suggests that some sort of a mechanoreceptor mediated sudden emptying of the right ventricle is the reason for the drop in the pulmonary blood flow, and consequently a drop in the systemic saturation. And the support for that theory comes from the response that you often find in cyanotic spell for a fluid challenge. The truth may be that there are multiple factors which are at play. Definitely a hypovolemia will contribute to worsening of the spell. A drop in systemic vascular resistance definitely causes a spell, and at least in some cases, a variable tone of the infundibulum may be contributing to the spell. It would be inappropriate to think that these theories are exclusive and one doesn't take into account the other. This is a simplistic illustration of the mechanism of hypercyanotic spell. You can see that there's a tetralogy here. Here is a large VSD, here is an overriding aorta, and here there is an infundibular stenosis. And during the spell, the infundibulum has clamped shut, and there is greater right to left shunt which is occurring into the aorta. Clapton is an important symptom that you would find in tetralogy in the older child. In the history, if a person who is cyanotic gives you a history that there is squatting, that's very, very suggestive that you are dealing with tetralogy fallow. But older children and adults, they learn to restrict activity and they may not squat. They instead may assume many squatting equivalent positions. For instance, sitting with legs drawn underneath. Many Indians are capable of sitting this way. Legs crossed while standing, the way Lord Krishna would stand. The mother holding the baby with knees drawn towards the chin. All these are squatting equivalent positions. And how do these positions help the baby in spell? When you are bending the thighs, there is an acute increase in the systemic vascular resistance because the femoral arteries are kinked. Also, the femoral veins are kinked, which leads to a lockup of systemic venous blood in the legs. And as you are drawing the thighs towards the abdomen, the better saturated mesenteric venous blood is displaced towards the heart. So even though there is a right to left shunt, What is shunting right to left now is a better saturated blood. So all these factors, the abrupt increase in the systemic vascular resistance, the locking up of the really desaturated lower limb venous blood, the displacement of the mesenteric venous blood into the heart, all these contribute to relief of cyanosis, improvement of saturation, and hence relief from the squatting maneuver. We also speak of cyanosis in certain special situations. You use the word differential cyanosis. It means the cyanosis is more in the lower limbs. It's often seen with clubbing. And to elicit this, you ask the patient to sit, or if he's sitting on a chair, put his hands alongside his toes, and you notice that the toes are clubbed and more cyanosed. It's a feature of Eisenmenger PDA because the lower limbs are receiving desaturated blood. In the newborn, if you are checking an SpO2 measurement, this is also a feature of primary pulmonary hypertension in the newborn, persistent pulmonary hypertension in the newborn, because one of the diagnostic features of persistent pulmonary hypertension in the newborn is a right to left shunt across the duct. And if you are checking the SpO2 in the upper limbs versus the lower limbs, you'll find that the lower limbs are more desaturated. You could get a reverse of this, what we would call a reversed differential cyanosis, in which the lower limbs are better saturated. If that is to happen, then the lower limbs should receive the better saturated blood. This can happen in transposition when it is accompanied by coarctation and a PDA. What would happen is that the left ventricle is pumping into the pulmonary artery, and a duct is maintaining the systemic circulation. So the better saturated left ventricular blood is perfusing the lower limbs. So you find that the lower limbs are fine, while the upper limbs get blood from the right ventricle and the aorta. And this combination you call a reversed differential cyanosis. Also, you find a person, an older child or an young adult, obviously cyanosed. You examine the heart looks normal. This is a feature of a pulmonary AV fistula, or a systemic venous anomaly like an SVC or an IVC, which is draining into the left atrium, can also result in a normal heart with cyanosis. Thank you. I would be happy to answer any questions. You could ask the questions as chat,